Morning, Dr. Nageshwar Rao and Jairangnath. Just
Good morning, Srinivas.
Good morning, Dr. Srinivas.
Yeah, morning. We have Dr. Nakul Sinha sir and Satyendra Tiwari, others here.
Okay.
I will hand over them. They will have a brief introduction. Go to your case.
Good morning, sir.
Good morning to everybody, and we are eagerly awaiting.
Thank you very much, sir. I would like to tell that my colleague Dr. Bhargavi, pediatric cardiologist, will present the case. Then Professor Jairangnath will speak about what is the strategy of the case and so far what we have done.
They will show. Oh.
Yeah, good morning, everyone. Good morning, sir. I'm Dr. Bhargavi. Today we are doing a case of pulmonary valve replacement. He is a 21-year-old male who underwent first Balak shunt at 2002, 6 months of age, and then intracardiac repair in next year. After that, he underwent again RV2 PA conduit because of RVOT aneurysm in 2008 using 20 mm Contigra. In 2016,
Coronary is far away, no?
and 2016, he underwent conduit change. Past, he had history of syncope, and his weight is of 110 kgs, height of 180 centimeters, and PSA 2.4. So he has ejection systolic murmur 3/6, and here there is severe RV. We can see the X-ray showing the cardiomegaly, and we can see there is a calcified conduit here, and ECG is sinus rhythm with heart rate of 90. Normal P-wave axis and QRS duration is about 180 milliseconds with our right bundle branch block. So when we have done the echo, there is RV dysfunction is there, and we can see the conduit is completely calcified.
And you ready?
And there is severe RVOTO to the patient, and there is a free PR with severe RVOTO. Then we
1 minute.
went ahead with the CT scan. I'll show the CT scan images. So here we can see this is a completely calcified conduit with a severe RVOTO.
Okay, go ahead.
And branch pulmonary arteries are fine. They're good size branch PAs. And with contrast also.
Angio.
So this is the calcified conduit. And we have the measurements. The measurement measures around the 24 mm in dia. So we have taken then for the RVOT measures like 24, main pulmonary artery 26, and branch pulmonary RPAs of good size 24, and LPA is around 20 mm. So we have done a cardiac plan where systemic artery pressures are 124/86 and 100, and RV pressure is of 98, which is around 0.8. RV to systemic ratio is 0.8, which is an indication for pulmonary valve transplant, pulmonary valve replacement. So there is a gradient from RV to PA around 78. So now after that we went ahead with the cardiac cath.
Can we have a quick clarification on a few points?
Yes, sir.
You said the conduit was implanted around 15 years back,
Yes,
and
sir.
it was changed. So it was a valve conduit, and there was a conduit in conduit change?
Yes, sir. Conduit in actually last OT records were not available, sir. That was the issue. Initial conduit was 20 mm Contigra. After that, the next OT notes we are not finding.
Okay, so when the conduit was changed, I mean what happened to the previous one? I mean, it was a surgical procedure, I believe.
It's a surgical procedure, sir.
Right. So
He underwent all 4 surgeries from BT, then 3 sternotomies he underwent.
right. So this time the plan is to make the valve percutaneously functional,
Yes, sir.
and then relieve the RVOT obstruction. And there
Yes,
was
sir.
no pulmonary regurgitation, I believe.
There was pulmonary regurgitation also, sir. Moderate pulmonary regurgitation is there.
Okay. Fine.
And our plan was to dilate the calcified one, stunt it, then keep a pulmonary valve.
Great. Please go ahead.
I think it's
Yes,
very
sir.
important for us to understand, apart from the echo, it's also
Mm.
important to understand the CT and to
Yes, sir.
decide on what is the sizing and similar to TAVR, I think the same valve is being used here. It's very important for us to understand the selection of the valve and how much oversizing we're doing. And can you, Nageshwar Rao or Ranganath sir, can you throw light on that of the CT findings and the valve selection?
No, the condio was, it was reported 24 millimeter condio. Okay,
Twen-
so the preliminary testing was done. The CT was also showing around 24 millimeter. It's a calcified valve. So we need to, all these are very highly calcified. Unlike the TAVI here, it is a bit difficult here. They're not easy. So we need to predilate them to make a way for it. Then we have to predilate significantly with probably many times we need to go with 2-3 graded dilatations. Then almost all the condio pulmonary valve implantations, we have to put a stent there. Covered stent, preferably, because we have to go to very high pressure. We cannot use the regular stent. That's the standard policy across the world. There's no, we cannot come back on that. So that is, we are trying to do that now. It's a very tough case. It's 110 kilo by heavily calcified. You are negotiating the conduits with stenosis, crossing to, and always we try to, in a pulmonary valve implantation, it's always try to keep the wire in the LPA, deep in the LPA, because that will give a lot of support to put a valve. Because unlike this one, we don't have a sheath up to the pulmonary artery. We don't have right now. So till such time that we need to keep the Elantra wire or a very stiff wire, whichever is available, in the LPA deep, like you can see. I don't know whether you are seeing that or not.
Show the angios, previous diagnostic cath.
Yeah, sorry,
Show
you
the
can show the diagnostic. And now I was told that Merrill has made a sheet which goes very close. I think
not
that
yet available. Not yet available. Still in the initial thing. Not yet
Okay.
available, that one.
Okay.
So
You can show the angios.
yeah, Anju.
Srinivasa,
Sorry to interrupt, madam. Finish the presentation. Show the angios before what you're planning to show.
No,
Diagnostic.
Bhargav, you can show some angiograms. Want to remove this?
Showing the angios.
Remove the sheet.
So this is the first we have done a diagnostic angiogram
You have to keep it there.
where our pigtail was in RV, and lateral angiogram where we
Test
can,
wire also waited.
we can see the contrast filling, and this is the completely thickened opacified RVOT with the calcium. That is in lateral view, and again in RAO view also we are seeing this is a thickened calcified calcium conduit.
How to remove that?
Srinivasa,
So then we have taken an Amplatzer sizing balloon, and we have balloon sizing was done across the RVOT, and then we have injected in the RV, and also the coronary angiogram was also non-specific was done to see the any compression when we have
You
balloon
explain the
dilating.
field.
So here the constriction portion of the balloon was coming around 15 mm. So that is the reason we thought of pre-dilate the RVOT first and then stent and then the pulmonary valve. So at present,
Yeah, I think you can go to today's.
so now we are going to today's,
Huh?
can we show this one? This is angio.
This is balloon this year.
so you do CT measurement in all the cases prior
Everything
to
is
the
balloon.
procedure?
We will do CT measurement in all cases with the calcium definitely, with the conduit definitely. If it is a dynamic native RVOTO, MRI is better, but when you have a measurement issue, then again we have to do CT angio. So most of the cases will undergo CT angio as a first point for the initial evaluation, and we'll get the idea about the coronary artery anatomy as well.
It is not coming back.
So we have a patient of 110 kilogram post-operative, multiple surgeries. Then now we just dilated the valve, show the valve, so dilated the conduit. We initially what we have done is we put a scene minus, minus, minus,
10 French
minus.
sheet.
So we put a 14 French Mullen's sheath there in the right ventricular outflow tract, and we took a 24 millimeter new med Z-med balloon. Next, please. That is the Lundercast wire parked in the LPA. Next. Next. Yeah. So this is the angio minus. Yes. This is the balloon and coronary artery anatomy. You can see that the calcified one is the constrictor portion, and we could dilate up to 90%. Then followed by that coronary angiogram given, and coronaries are away. Next, please. Next. So the balloon seen minus, 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 yeah, minus.
Normally in TAVR, we take little undersized balloon to predilate. You do 100% dilatation or do little undersizing?
No, this is 20 millimeter.
20 millimeter.
Yeah.
Initially we used 24.
Yeah.
We kept it there.
20,
Yeah,
this
same
also
thing
20
is done in
This is
aortic
a
valve.
20 G-med balloon. Then the calcium gave a constriction. Then after that, the balloon got burst there. So the burst balloon, we are removing it right now. So we'll get back to you afterwards.
Okay, then can we have a lecture and come back to you? Or
Yeah,
what,
yes.
whatever you
Yes.
say.
Yeah,
Yeah.
that is correct.
Yes,
Yeah.
yes, we
Hello?
can hear you.
Yeah, we will show what we have done. Show the balloon, please. So this is what when we left you. So we dilated with 20 balloon, and the coronary angiogram showed that it is very well away. Then the balloon, even though we use a new balloon, balloon actually got burst, G-med balloon, because of the stiff calcium. Then we removed the balloon got stuck in the sheath. I put another wire in the LPA. Then we removed the 14 French sheath and balloon together. We did not lose the axis. Then we advance the next. So next. So we advanced 16 French Cook's Mullen's sheath over there. Then we used a 40 into 22 millimeter stent, CP covered stent. You can see that the CP cover stent mounted on Atlas balloon. That is Atlas gold will have 3 markers. That the distal marker, we intentionally kept the stent more proximally here. While you are going, sometimes the stent may migrate into distal, that is the reason. So we have balloon position. Next. That is the check angiogram. So we are satisfied with that position. Next. So we inflated the stent. We went up to 6 bar here. We completely inflated. So now it is at 21 millimeters of annulus diameter. We have removed the sheath. Next. We have removed the sheath. The Lundercast wire is there and pacing wire is kept. Now this is the valve. The my valve, which is in a reverse position loaded. My valve is designed only for the aortic valve position. Jay will take over and tell.
No, at this point, I think we are having difficulty in getting across the valve. So we are generally next. Yeah, here it comes and gets stuck there. So now we are planning to put another buddy wire from the left side. Here it is stuck there. We're not able to get into the area where we want to put it into the stent. So we'll have to do some maneuvers now, in the sense that we need to probably put a buddy wire and take extra support and do all that. So we're in that process of doing that.
So we'll put a buddy wire and then we'll put a balloon also proximally sometimes, so that the stent will go, the valve will go within the stent. So now we are, the live is, you can see the valve is the Lundercast wire. Can you show the live fluoro, please? Live fluoro. So this is the live, the Lundercast wire position is good. The valve is just crossed the tricuspid wall and the right ventricle with a pacing wire. I can advance the valve, but valve will go up to the stent. So what we want to do is, we would like to put another RCA catheter, put an amperage extra stiff wire here, and then manipulate the valve. If that doesn't work, then we'll put another small balloon there, around 14, 16 balloon, and then advance it. I hope that will work. We'll get back to you and show whenever you get a time. Is it okay?
Well, please go ahead and take your time to sort of advance the valve. So you
Okay.
said one option is that you will negotiate with the help of a balloon which is ahead of the valve. Am I right?
Yes.
Right. And the second option you were saying?
First option is we'll put a buddy wire. Buddy wire will make the another wire to come away from the stent, so that we'll get some space to advance the pulmonary valve. If that doesn't work, then we'll put the balloon.
Okay. So
Okay.
So you can go ahead with your lectures and we'll come back.
Yes.
Yeah, we are with you. You can show the
Yes,
final.
sir.
result.
Yeah, we are ready.
Yeah, please show, sir.
Lateral. So what we have done, show the scene minus.
We are into the coronary session. Sorry to interrupt the CTO session. Just show briefly what you have done and then we have to go
It's
back.
almost done.
So as I described that we have actually put another buddy wire. Show that.
Yeah, go ahead.
Towards you. So that is the stent position.
Okay.
Are we removing or we are keeping there? So this is the stent. Shravan, is it okay position?
Yeah.
So we are placing and then deploying the stent.
Okay, go
Place
ahead.
please 200.
Yeah.
Yeah,
Go.
deploy.
So we are deploying. Yeah, facing off.
Yes, sir.
Okay.
Fluorosave. So we decided put a little bit forward because there is a tough calcium at that level. So we thought little bit forward when stent is getting covered. Now cover stent and then pulmonary valve is deployed there. Patient BP is good, heart rate is quite stable. We deployed at 200 pacing rate.
Yeah.
Jay, you want to give a comment? Get a multi-track catheter.
No, we had some difficulty, Rakshinos, as we told you that, but
Yeah.
we put a buddy wire. Then we had to go with a reverse looping. The straight one did not work. So
So
Show the-
scene minus, scene minus.
So take a final angio and then complete the
Yeah.
case.
we'll take the final angio.
Minus.
Minus to the pigtail.
So this is the reverse loop. So we thought it is not negotiable. That's why we put a reverse loop. You can see the two wires in the fluoroscopy. With the reverse loop and the other buddy wire, we could able to manage the valve to go across the stent here. So, and the calcium is tough, calcium is there. We thought we'll avoid that calcium to the main part of the valve in case again it gets ruptured or it doesn't open. That's why a little bit distal portion we preferred. Scene
I think-
minus, scene.
I think great demonstration and a lot of learning. Thank you, Nageshwar Rao. We are forced
Okay.
to break because other center CTO cases are asking us to
Please
come
go
back.
ahead, Dr. Srinivas.
Thank you,
very
thank
much,
you.
Dr.
Thank you.
Srinivas, for this
A
opportunity.
round of applause from the hall to
Great
you.
job.
Thank you. Thank you.
Professor Jayranganath is from JWCC Institute. He
I
has
know.
got a wide experience of pulmonary valves.
Everybody knows sir in this audience. No? Thank you, sir.
Okay, thank you.
Thank
Now
you.
this was a bit tough. Sorry, we could not show you full on live. But
No,
we
no,
didn't want
no.
to lose our this thing, concentration. Yeah. Thank you.
Thank you, sir.